everyone. I want to thank you for joining us for our presentation with Stop HIV, Screen, Treat, Overcome, and Prevent Engaging Convenient Care. My name is Nate Bronstein. I'm the Chief Operating Officer of the Convenient Care Association, and it's my pleasure to begin this program, which is a part of our Convenient Care Weeks. With that, I would like to turn things over to Faith Rogers.
Nate, thank you so much. I'm Faith Rogers, Program Manager at DKB Med. Happy to be joining today for Stop HIV, that's Screen, Treat, Overcome, and Prevent HIV. This is topic 2, now what? So on testing and treatment. Today we do have 1 contact hour available for participating in this education through the American Public Health Association for nursing. And on the next slide, we have Pim, who is accrediting for AMA PRA Category 1 credit. And again, that is also for a maximum of 1 hour. We're very fortunate to have 2 wonderful faculty with us today. We have Justin Alves, a clinical nurse educator in Boston. Justin, feel free to introduce yourself.
Hi, everybody. My name is Justin. As Faith said, I am a nurse educator here in Boston. I am certified in taking care of people with HIV/AIDS and in addiction. And so I'm really excited to talk to you about this and how do we sort of make HIV treatment and PrEP work in convenient care settings. Thanks so much for having me.
Thank you for joining, Justin. And then we also have Melinda Pipik from CVS Minute Clinic. She is a sexual health peer mentor. Melinda, thank you so much for your time. Feel free to introduce yourself.
Thank you. My name is Melinda Pipik. I am a family nurse practitioner. I'm currently working with CVS Minute Clinic, so I am your convenient care provider representative for this presentation. Part of my job is to offer not just sexual education to our patients, but also to my peers. And so we offer that service to our colleagues that if you have any questions or concerns about sexual health, you can contact one of your peers, and that's a role I play in my current job. Super excited to be able to share information on PrEP in the convenient care setting today during this presentation.
Great, thank you so much. These are our faculty's disclosures. So they have indicated they will be discussing the unapproved and unlabeled use of, I'm not even going to pretend I know how to pronounce that, but you can read it here, for on-demand PrEP and to prevent acquisition of HIV through injection drug use. This activity is made possible through educational grant provided by Gilead Sciences Incorporated. All activity content and materials have been developed solely by the planning committee members and faculty presenters. Today's learning objectives are to assess eligibility for pre-exposure prophylaxis among patients seen in your convenient care practice, and also to describe the benefits of rapid initiation of ART for people with newly diagnosed HIV in the convenient care setting. So with that, the question and answer, please use the question feature in Zoom during the presentation. The Q&A portion of the program will follow the presentation. So looking forward to seeing what questions you have for our faculty today. With that, I will hand it off to Melinda.
Hi, thank you so much. So before we talk about the guidelines, I just want to get out there that we have in our previous presentation, we did reiterate that there is an overlap of patients who are newly diagnosed with HIV every year and patients who utilize convenient care services. So there is a need in the convenient care setting for us to be offering health promotion and health prevention services, particularly in the area of HIV testing. So this is a great topic for convenient care, and it's a great service to provide in convenient care. So I'm going to tell you a little bit more about it now, about PrEP in the convenient care setting. So, but first off the bat, we want to talk about how do we test and when do we test for HIV. So again, we talk about the CDC guidelines. They are the gold standard of guidelines. So this is what we should be following in every clinic across the country. All persons aged 13 to 64 should be screened for HIV at least once. Unless you're in an area where the prevalence of undiagnosed HIV infection is less than 0.1%, pardon me, but then you should just plan on offering that service to everyone between ages 13 and 64 at least once. And then all persons starting treatment for tuberculosis, every person seeking treatment for sexually transmitted infection should be tested for HIV along with their other infection that they're being tested or treated for. Persons at higher risk for HIV infection should be screened at least annually, and then with the consideration for a little bit more frequent testing, either every 3 to 6 months, depending on their individual risk factor, or if there's an increased rate of HIV infections in that community locally. All persons with signs and symptoms consistent with an HIV infection or an opportunistic infection. So if your patient comes in for something unrelated to testing, but they have the signs and symptoms of HIV infection, which we'll go over, then you want to tack on HIV testing at that point. So let's talk about testing for HIV. In the convenient care setting, you have a couple different options. The number one option that is used not only for screening, but also for confirmation testing is the laboratory-based standard testing. The lab testing is a send-out lab. It's a 4th generation P24 antigen and antibody test, and you can use that for routine screening or for deciding on opting to order and provide PrEP treatment. This is, again, the gold standard of treatment. In the past, this lab may have taken 1 to 2 and 3 weeks to come back. It does not anymore. So even in the convenient care setting, not having access to a rapid test if you're only ordering testing via lab should not be a barrier for testing for HIV. Even if you're if you're sending out the lab in your clinic, it's up back in 2 days. If you give them a patient an order to go obtain the lab at an outpatient facility, either way, it takes about 1 to 2 days. It does not take very long to get these results back anymore. So just know that when you're ordering it, you will be in contact with these patients within a few days. Now, the patient must be brought back for results. The way to handle that situation in convenient care is you should schedule a follow-up with all of your patients who you're giving HIV testing for. Now, if you look at your corporate guidelines and your convenient care guidelines, you probably have something in there that says if it's negative and you have good follow-up, you can talk about that over the phone. But the flip side of that is a positive test has to be given in person. You have to give that in person. And so if you give the patient the option of, well, we'll call you if it's negative, but if it's positive, we have to bring you back, then we might not get them back for their positive. Then if we tell them they have to come back, then they might not want to come because they might be scared of the results. So it's good practice to just schedule a follow-up to go back for the results in 5 to 7 days. But if everything is covered and you have had a good rapport in the initial conversation, they have good follow-up, they have a phone, you've identified they have a phone number and they're reachable and available to talk, then if they come back negative, then you can decide later on to call them versus giving them in person. But a positive test has to be given in person. So that's your lab option. There are a couple rapid HIV tests on the market, and they are in use in convenient care right now. So the most standard test in use is a rapid HIV antibody test. They have a great testing window, usually a testing window of about 2 weeks after exposure. Other advantages, results within minutes, about 20 minutes on the test. It increases by having that access right there in your clinic. You are increasing the access to prevention and intervention. So if you know in 20 minutes what your answer is going to be, if it's positive or negative, that gives you the next step to be able to help your patients in deciding what they want to do after they get their HIV test. Very minimal to no equipment required, a very minimal technical skill. Most of these tests are blood or finger pokes, very easy to do at the bedside and in your clinic. If positive, though, we definitely recommend you do have to confirm that with a lab-based standard testing. So those are all the positives of rapids. And there are HIV antigen and antibody tests on the market, but the majority of them are, majority of tests in the convenient care setting and in the overall POCT world are HIV antibody tests. HIV rapid tests have a couple downfalls. You might miss a recent or acute infection. So you have to keep that in mind. So when you're deciding on what test to use, you have to look at what the pros and the cons of each are, the laboratory versus the rapid. What do you have in clinic? Because really what you have access to is the best test. You want to use what you have. And if the best test is you only have a lab, then send it out. Or if the best test is I only have a rapid in this moment in time, then you use it. If there is an acute infection suspected, then so if someone walks in symptomatic and you have utilized so you really have to utilize your sexual health history that Justin talked about earlier. You have to rely on not just which test to use, which you have available to you, but also what is the patient saying in their history. If their history means that they're at risk for multiple exposures throughout the past 6 months, then you want to make sure you're doing a lab testing if you have access to that. If your patient is symptomatic and their history is concerning, by symptomatic they have chronic fatigue, they have unexplained super infections like they have tuberculosis, or they have thrush and they're a super young person, then you want to, you want to do an HIV test, but then you want to also add on a viral load to that, because there might be more of a suspicion. We're not just screening, we might be leading towards diagnostics. So who's eligible for PrEP? And we'll talk about what is PrEP. PrEP is pre-exposure prophylaxis for HIV. So this is not for patients who are living with HIV or AIDS. This is for patients who do not have HIV. It's to prevent the transmission of HIV for these patients. And it's a daily pill regimen. It's approved for use in people who do not have HIV, and we want to reduce their risk of acquiring the infection. There are 2 formulations on the market right now. Both of them are a combination pill, and they're both taken daily. It's just a daily pill you take. These are the medications. So I'll be referring to them throughout the presentation as either TDF or TAF or TAF. So the TDF refers to Truvada. That medication is, it was the first one on the market for PrEP. It is the most widely used, but there is a newer medication called Descovy, and that one is TAF-FTC. And this one is a little bit newer. And then if you compare the 2 of them, so we know that the first one, the TDF, is newer. Sorry, it's more established. A couple of things that you have to keep in mind when you're prescribing PrEP is their kidney function, their bone density, and if they're effective at the tissue level for use. So when it comes to TDF, you have to have a creatinine clearance of over 60 milliliters per minute, and I'll talk about that in a later slide. Whereas with TAF, you can have a little bit weaker kidney function and have a creatinine clearance of only 30. With the TDF, there's a small risk of kidney or bone toxicity, and that's even less for TAF. So for TAF, it's also a smaller pill. So if you have someone who's averse to swallowing bigger pills, this might be a better option for them. On the flip side of that, we know that TDF is good for on-demand use in men who have sex with men, MSM, and the transgender women population. It's approved for all at-risk populations, whereas TAF is not indicated for prevention of HIV from vaginal sex. There really is no published protection against HIV at the cervical vaginal tissue level with TAF. So this one would not be indicated for all populations, whereas the TDF is.
I think just another important point to add there, Melinda, is that when we think about people who use injection drugs, the studies were done in tenofovir disoproxil fumarate. And so just really identifying that for all comers, if you're only going to learn one of these, learn the tenofovir disoproxil fumarate, the TDF, because that you can give to anybody unless they have bad kidneys. And then TAF really is this smaller cohort of just men who have sex with men and trans women who are having anal sex.
Thank you, Justin. So who are we going to be offering PrEP to, right? So PrEP is for people without HIV who are at risk of acquisition from sex, at risk of acquisition of HIV from sex or through injection drug use. People at risk who should be assessed for PrEP include sexually active men who have sex with men without HIV, sexually active heterosexual men and women without HIV, sexually active transgender persons without HIV. This is a large portion of the population, right? So this is a large service population that we can be treating. And then persons without HIV who inject drugs, persons who have in the past been prescribed NPEP. So NPEP is non-occupational post-exposure prophylaxis, and that happens either through a condom breaking, an anonymous experience, trauma, a traumatic sex experience. If a patient has reports that they were previously prescribed NPEP, and then you assess their risk and they're continually at risk for needing NPEP, then that's someone you want to transition over to the PrEP and offer PrEP to, the pre-exposure prophylaxis. And people who ask for it, if you ask for PrEP, we're going to screen you for it for sure. So how are you eligible for it? The hard stop here is you got to have a negative HIV test. So whether we test you, how we kind of talked about what the way to test patients is for, the test has to be negative. And we want to know that there's no recent risk exposure in the past in the testing window of our test. So you got to have a negative HIV test. We also want to make sure you're asymptomatic for signs of acute HIV. So if you have a symptomatic patient with fever and sore throat, rash, headache, now in the convenient care setting, this is a huge portion of our population. We do a lot of URI. We see a lot of strep throat. So again, you have to rely on your sexual history to decide. Just because someone has a sore throat and a fever from strep, that doesn't mean that they are not eligible to get PrEP. So you want to utilize your sexual health history to decide if your symptomatic patient is also someone who can be for PrEP, or if your symptomatic patient is someone who actually might be showing signs and symptoms of acute HIV. No contraindicated in medications. So we will talk about that a little bit more, but you want to make sure that someone isn't taking a medication that would be mostly toxic to their kidneys. We want to make sure that we've documented the status of hepatitis B. So just because you need to know that if you are going to offer someone to PrEP in your setting, and they do have a history of hepatitis B infection and it's chronic, if you were to discontinue it at any set stage in the game, if you were to discontinue your PrEP at any time along the way, you can trigger a hepatitis B flare-up, and we don't want to trigger patients into that if we don't have to. And then finally, your kidneys have to be working. Your creatinine clearance has to be greater than 30 milliliters per minute. Okay, so when should PrEP be considered? I cannot stress this enough. If the patient requests PrEP, if they request it, we're going to consider it, because just by requesting it alone, even if a patient doesn't want to go into it, why they go into you in that setting, why they're requesting it, there's a reason. So if a patient is requesting PrEP, you definitely consider it and give them your options of what you provide in your clinic. We should also consider it if you're diagnosing another STI, or if someone believes they were exposed or they want testing for STIs, you're going to tack on an HIV test, and then you're going to say, if this comes back negative, I think you're a good candidate for PrEP, and we can talk about it. If a patient reports that they have inconsistent or infrequent condom use, if they have the recent NPEP, like we just talked about, if they request HIV testing, then you're going to go right into, if it's negative, we should talk about PrEP. If a person has a partner with an HIV infection, no brainer, you want to offer PrEP and screen for PrEP and talk about that with that patient. If a patient, you're going along your visit and they happen to express, by the way, I think my partner has other partners or is not monogamous, you can validate those concerns and offer protection through PrEP. If your patient is having sexual activity in a high prevalence area or network, or if they're participating in transactional sex, either for money or drugs or rent, then you definitely want to offer them PrEP. If someone is using drugs or alcohol, especially in relation to sexual activity, where their ability to make decisions about sexual activity and protection can be altered by drugs or alcohol, then you definitely want to offer them HIV protection with PrEP. Use of injection drugs, and a history, if your patient has been incarcerated or their partner has been incarcerated, definitely offer them PrEP and HIV screening. So who should not be prescribed PrEP? There's only a couple contraindications. There's the one hard stop. If you're already living with HIV, if you have a confirmed status that is positive, you should not be prescribed PrEP. This is not for you. There are options for you, but in the PrEP situation, we do not want to be offering PrEP to someone who is already HIV positive, which is why it's important to test appropriately, important to know what tests to use and how to test. If you have a patient at high risk for acute retroviral syndrome, you can always check if you're concerned for that at the time that you're screening for HIV, you can check the HIV RNA PCR, which is the viral load, because we know that the current PrEP agents would not meet the needs of a complete HIV treatment regimen. So that's also the bigger picture, is we're not servicing our HIV positive population by only offering them PrEP. They're just not, it's not enough medication to treat them as adequately and effectively as they need to be treated. And then patients with renal insufficiency, the creatinine clearance for TDF needs to be over 60 and the creatinine clearance needs to be over 30. Okay, creatinine clearance is very easy to find. We're going to go over what labs to draw when you have them come in. But you can search at NDCalc is a great website where you can find creatinine clearance. You can memorize the Cockcroft-Gault equation, or you could just plug it into your MedCalc online app. You will need a wait. I'll talk about that later on. If you're screening someone for PrEP and you're going to be drawing labs, make sure you get a wait. But overall, we want to make sure for PrEP, if you have someone in your community care setting who doesn't know they have renal insufficiency and you get their labs back and their creatinine clearance is less than that threshold, you got to be, we have to be referring them out. They're not good candidates for PrEP. So 2 things to note. Number 1, as you'll see, a hepatitis B infection and continued injection drug use are not contraindications to PrEP. In your setting, you might want to check your guidelines, because if somebody does have concurrent hepatitis B infection, they may not be a candidate for you to keep them in your care for PrEP. But that doesn't mean that they can't get PrEP. You just want to refer them on to the right community care provider. The other contraindication that you don't see here is risk. Someone's risk or lack of risk factors is not a contraindication for PrEP. So and just to reiterate what we said in the last slide, if somebody is asking for PrEP, but they deny being sexually active, they deny having an HIV positive partner, they deny any risk factors, that does not make them not a candidate. There is a reason they're asking. So risk factors are not a reason why we should not be prescribing PrEP. Okay, let's talk about the baseline testing. Now, if you are seeing patients in the community care setting, this can seem overwhelming, right? All these tests I have to run. It's not. Check your corporation's guidelines, and then you're just going to go step by step. In an optimal world, the patient pre-schedules, you have 30 to 40 minutes to go over this. But even if they don't, these are things that you can kind of check off within your 20-minute visit. So number 1, you got to talk about HIV testing. So that has to be done. When you're prescribing PrEP and it's solely on the results of antibody only rapid tests, that's fine. If that's right for your community, if that's what's offered in your community, that's fine. But you're going to be drawing labs anyway to check for their creatinine clearance. So just tack on an HIV test because you will need it you just want to make sure you're confirming their HIV status appropriately. So and by doing that, you increase the likelihood of detecting unrecognized infection, and so that we can stop PrEP if we need to, and you can point them in the direction or start them on an antiretroviral treatment if in a timely necessary if needed. So tack on the HIV lab test, even if you're doing a rapid in clinic, if you're going to be starting PrEP. In this first appointment, where you're going to be screening someone and deciding if someone is a good candidate for PrEP, you're going to be doing all the STI screening. And you're going to be doing it from all the sites that they are sexually active. So you're going to do urine, gonorrhea, chlamydia, and trick. You're going to be doing oropharyngeal gonorrhea and chlamydia, and you're going to be doing rectal gonorrhea and chlamydia. And then also I want to send off syphilis testing, serum syphilis test, and a hepatitis C virus antibody titer. Those are all going to be included in your lab draw and your lab order. Any patient who can get pregnant should be tested for pregnancy before you start PrEP. And then talk about the creatinine clearance. For TDF, it's got to be over 60 milliliters per minute. So you can order on a BUN and creatinine, or you can just do a BMP. I think most facilities just include a BMP. If they have a set order set for how to provide PrEP, a BMP is right in there because you're looking for that BUN and creatinine. And get a weight. If you don't get a weight and they leave, you got to call them and get a weight. You can't calculate that creatinine clearance without it. And then screen for HBV. So in addition to your serum HIV labs with your hepatitis B, your HIV, and your HCV, you're going to add the HBV for 2 reasons. Number one, we want to identify infection. So right off the bat, it's for the patient's health. We want to identify infection if they do have hepatitis B. But also, we're in convenient care. We have vaccines. And if you are negative for HPV surface antigen or core antibody, and if your testing comes back and it says there's no evidence of immunization, we can vaccinate you. So that's really nice. So you want to screen for HPV for those two folds. Okay, and then follow up for people prescribed PrEP. This is the easy part, right? So the hard part is how do I test you? What do I have to do? How do I prescribe it? This is the easy part. Just come back in 3 months to see me. So we know that a couple things about this is that if you're already presenting to our clinic because you're interested in health prevention, then we'll see you in 3 months. You can anticipate seeing these patients in 3 months and being very compliant with their medication regimen. So at the 3 month mark, for sure, you always need an HIV test every 3 months, and you got to look at them, lay eyes on them, make sure that your patient isn't showing signs of acute infection. That's a hard step. If they're not coming in for HIV test every 3 months, you unfortunately can't continue to prescribe without seeing them. You also want to, at the 3 month follow-up, you also want to talk about medication adherence. Are there any issues with taking your meds? Are you having side effects you don't like? Are you finding that when I have school, I can take it at this time, but when I'm not in school, I can't remember? You want to talk about methods to help with adherence, and then behavioral risk reduction. Are patients, are you still engaging in riskier behavior? Have you noticed that you're not as risky right now because you're on PrEP? So those are all counseling you want to provide at the 3 month mark. You do want to do STI symptom assessment and testing. So for sure, you want to do that in the beginning and then every 6 months. But if at any point your patient says to you, I'm PrEP, and you know what, I've not been using condoms and now I have this burning or I have this other symptom, you definitely want to test that and treat that infection as well. You should be providing, if your patient is coming in with an HIV test every 3 months, then they get a 90-day refill and helps with compliance by giving that longer refill that helps the patient not have to come in every month. It gives them the 3 months to take their medications. And again, it helps with compliance. Every 3 months for patients who are at risk for pregnancy, you have to do a pregnancy test. And then maybe something changes. So not just the pregnancy test, but assess pregnancy intent. Has anything changed? Have you decided in the past 3 to 6 months that you might want to get pregnant at this moment in time? So you want to assess that 3 month visit. And then you want to be in touch with your local service, the clean needle services around your area, because you want to offer clean needle syringes and drug treatment services for people who use injection drugs. So you want to make sure you're assessing that risk and hook them up in the right direction if that's still a risk. So the renal function you do initially, you do it at 3 months. And at the 3 month mark, if your creatinine clearance is holding out, if you're well above 60 at the initial or 30, depending on your medication at the initial, and then at 3 months, after that, you're good for every 6 months. So basically, you just kind of make a grid for yourself or for the patient, and you know every 3 months, you're going to be doing HIV testing. Every 6, you're going to be tacking on, if their creatinine clearance stays good after the first 3 months, then every 6 months, you're going to be tacking on more testing, the renal function test and the STI testing. And then every 12 months, you have to continue, evaluate the need to continue PrEP. So if you have that first conversation, every 3 months, you talk about how's it going, how are things going. But if the need to continue PrEP, you want to make sure you touch base on that at least once a year. Before your patient leaves, before they go out in the world and you've given them the prescription for how to take their medication daily, a couple of key points you want to hit. You want to make sure you offer the education. These are the potential side effects. They should know what to expect in the beginning. Typically in the beginning, nausea, it gets better after a few weeks, but typically there's a little bit of nausea in the first few weeks of starting the medication. We want to prepare them that even though your kidney function is good now, you might have a little bit of a dip in your kidney functioning. So we're going to check that for you. But also in the meantime, we want to make sure you protect your kidneys. Make sure you're staying hydrated. If you're going to be on this medication, maybe avoid daily Motrin or daily Aleve. And if you have some pain, take some Tylenol. But you want to avoid anything that's going to really tax the kidneys. Make sure you're not putting yourself in a chronically dehydrated state. Make sure you're drinking liquids all the time. And make sure you're not, if you're going to be drinking lots of coffee, make sure you supplement with the water on top of it. So that's education we want to give. We also want to tell them you may have a little bit of a decreased bone density, and then you might have a potential weight gain, just about 2 pounds if you're on the TAF. Adherence. Now, you might have a patient who is super concerned that they're going to forget a medication or forget a day. So what we know is that the effects of non-adherence with PrEP, so maybe you don't take it every day, you still get 92% protection. So there's a level of 92% of effect of the detectable drug in the plasma, even if you're not taking it every day as that we want to. Now, of course, we want to have our patients take it every day. It's most effective if you take it every day. But if you have someone who's really has a lot of anxiety about missing a pill, then you can give that reassurance. Risk of resistance. This is a big deal if you have a patient with acute HIV. So you have a risk of developing resistance to HIV medications if we don't identify that you have acute HIV in the beginning, which is why we have to test you appropriately. And we also need to look at you appropriately. If we want you to contact a primary care provider if while we are going along, you develop symptoms of HIV. If you develop a sore throat, a headache or a rash, then we want to refer you on. Quick note about the time to protection. The patients always ask that question. There's approximately 7 days that you start getting protection after PrEP. So patients will always ask you that, when is this effective? 7 days in a row, and then after that you have protection in the rectal tissue for TDF. And then for vaginal sex, it takes about 20 days for it to be effective. This has not been studied in TAF, so because it's not effective that we know of right now for vaginal sex population. So it's for the TDF population, it takes 20 days. And then one more note, PrEP only prevents HIV acquisitions and not other STIs. So you got to be using condom use to protect the other STIs. I'm going to talk about one major barrier to PrEP, and that's cost. And that is what gets providers bogged down all the time, is when if you have a patient who, because when insurance companies will definitely provide, cover your labs. But if you have a lack of insurance, or say there's a medication problem with your insurance, there are cost, there's access to care for cost. There are ways to help you. Gilead, who is the company who has created TDF, they have on their website, they have lots of different methods for how to get your patient who needs PrEP that medication at low to no cost. A bigger, one of the other concerns is how to get the labs covered. And so labs are a little bit harder to get covered if your patient doesn't have insurance, but there's Ready, Set, PrEP programs in each state. Just check your state's availability of how to get labs done. Sometimes there's, lab vans that go around every couple of weeks in different smaller communities where you can get cheaper medication, cheaper labs drawn. Really, the cost and the provider lack of PrEP awareness are the two biggest barriers we see. And that's what this presentation is for, to kind of help you get over that lack of awareness. And then there is a little bit of a stigma sometimes being seen as taking something that confirms promiscuity, or even might make people think you have HIV, might be a patient's barrier to seeking PrEP. And then a hepatitis B infection, it might be a little bit more complicated in the convenient care setting to provide PrEP to someone who has hepatitis B, but they can still get it in a different setting and helping them get to that appropriate setting. And then an adherence issue, sometimes patients don't want to take daily meds if they start, if they're not feeling sick. Why take it? I'm not sick. So those are a couple barriers to get over with. And then this is, again, how to help patients pay. So the Get Your PrEP, the Gilead website, and then check your state's website. I cannot stress that enough. Every state has a little bit different coverage and offering for how to get patients PrEP. And right off the bat, if you're in a convenient care setting that is located in a pharmacy and you don't know, call a pharmacist. They can also help you. So if you're not quite sure who to call a pharmacist, or call Gilead if you have a second. But don't do a hard stop if someone can't pay. Start with one phone call, call somebody, and then go on to the next step, because there are options for your patients to be able to get their PrEP. And then I'm going to hand this over to Justin to talk about PrEP and development.
Yeah, thanks so much, Melissa. I think just a few things just for folks to know that's coming down the pipeline. So they are looking at expanding sort of the catchment area for tenofovir alafenamide to help some of our non-rectal sex having or vaginal sex having folks access to a medication that's safer and lower kidney function. Then we have two other really cool medications down the pipeline: long-acting cabotegravir, which in the HIV trials prevention is already actually approved for treatment of HIV, and we're looking at it for prevention. And then long-acting islatravir, which is another oral medication that's going to be dosed monthly. So we're really excited about that, especially for our folks who have trouble with daily adherence with medications. We think that these could be game changers. So stay on the lookout, because that might be just like your vaccine in clinic. You can just give a shot and call it a day. So I think, Melinda, we talked about this, like what happens when the test comes back for HIV? What's sort of your thought process?
Well, there's like a shot of nerves if it comes back positive, right? Like, what am I going to do? It's positive. We know if it's negative, we're going to be offering PrEP. And that's what and we also want to tell the patient, if it's negative, we're going to offer PrEP. But if it's positive, then it's like, oh boy, now what do I do?
Well, and I think that that's like everyone's reaction. I remember I was saying this story earlier. When I was a new nurse, the first time I had to tell someone they had HIV, like my stomach was like sank, right? Like through my body. And I was like, oh my God. And I think just as a helpful reminder to everybody on the call, always remember you have the information, the patient doesn't. So it's your anxiety. Don't pass that on to the patient. What I want you to remember as we go through these slides is that you're going to be fine, the patient is going to be fine, and you're going to change their life for the best. So let's say your patient does test positive for HIV and you've got to bring them back in. This is why I always preset patients to come back to the clinic to get their HIV test result. I want you to come back on Tuesday and we're going to get your result. Whether it's positive or negative, you're coming back because either you're going to start PrEP or we're going to start treatment for HIV, right? I think every HIV test, you sort of have that opportunity to say, we're either going to help you prevent a new infection or we're going to treat the infection you currently have. And really it's about maximizing and durably suppressing HIV viral load as quickly as possible, because we know undetectable is untransmittable, and we know that treatment of HIV reduces both morbidity and mortality in this patient population, both immediately and in the long term. And so looking at the DHHS recommendations about initiating antiretroviral therapy, it used to be back in the day, many of you may remember this, we don't start HIV treatment until like the patient is ready, like they have to be really serious about taking the medicines. We only have a few in our arsenal. And now we know that's garbage, right? In today's world, we don't do that. In today's world, we offer treatment immediately or as close to diagnosis as possible, because we know that it is going to both help outcomes for the patient, protect the community, and we have a ton of medicines in our arsenal, so we're not as worried about developing viral resistance should the patient struggle taking medicines every day. And so when do you start treatment? Well, so two giant trials, the START trial and the Temprano trial. Do you need to know everything that happened in these trials? No. What you need to know about these two trials is that they irrefutably told us we want to start HIV treatment even in healthy people. We don't need to wait for people to get sick to start treatment. Really novel in medicine, right? We know prevention works, and we know if we can be proactive in protecting people's health, that we're actually going to have better outcomes in the long run. And that's what both of these trials really looked at, was reducing morbidity or mortality related to HIV, even in treating patients who were well and not sick. And so this is just a quick snippet of the types of drug classes. This isn't even the number of drugs. This is the drug classes that exist to treat HIV. For those of you who remember back in the day when there was just one drug, AZT, like this is revolutionary, right? We have things like monoclonal antibodies, we have pharmacokinetic enhancers, we have TCR5 antagonists. These are all these medications that have come on the market and really changed the way we do treatment for HIV. Important to remember, when we're treating HIV, we're actually going to use medicines from different classes to treat HIV, because that is actually how we're going to get the biggest bang for our buck. And you might say, but Justin, this is really hard. I can't even say some of those words. Don't worry about it. We co-formulated stuff into one fancy pill. So all you have to remember is I have to prescribe one pill, right? We're gonna make it easy for folks. So what are the initial characteristics to think about for anyone with HIV? So you get that call, you're like, oh my God, it's positive, I have to call the patient. Don't freak, just think, what information do I need now? Well, the information you need now is the person in front of me healthy and well? If they're healthy and well, chill out. We got plenty of time, right? Like we can get the labs, we can know what's going on, and we can help this person for the better in the long term. So we're gonna look at getting an HIV viral load, a CD4 count. If your setting offers HIV genotype testing, that's great. In HLA B5701A, that test is gonna tell us about other regimens that can be used. And then we're going to think about, is this patient going to be able to take multiple pills a day? Probably not. Right? Like I have a hard time remembering my daily multivitamin, right? And so we really want to reduce pill burden as much as possible and make this super easy for patients to start. So you want to look at comorbid conditions. Now in longitudinal care, like we're thinking about like people living with HIV into their 70s and 80s. So we have to be worried about things like osteoporosis and hyperlipidemia, these things that we never used to worry about because folks were dying at 20, right? And so thinking about what medicines are going to have the least amount of side effects long-term. And again, don't fret. I'm going to give you two really good options for you to learn, and you're not going to need to learn the whole litany. You're just going to need to learn a couple in your tool belt. Think about, is this person pregnant? Pregnancy is not a contraindication to start medicines for PrEP or for ART. We want to start those things. The only thing we want to do is we want to make sure we get people into prenatal care if they're pregnant, right? We want to think about co-infections. Beauty of HIV treatment is some of them also treat hepatitis B, right? So we can actually get a twofer there and thinking about, are there other interactions with things like Hep C meds or TB meds? And that's where the drug interactions come in. So the DHHS guidelines, super, super fancy. All of these different 3 letters all represent one drug within HIV treatment. And when you see the slashes and they're 3 drugs sort of together, that means it's co-formulated as one pill. So what you can see here is these are the recommended initial regimens to treat people with HIV, right? And they are all sort of been tested, multiple studies to say that these are the regimens that prevent viral escape, meaning prevent resistance. They're tolerable to patients. Patients can take them without a lot of side effects, and it's not toxic to patients, and ease of use. Most of them are 1 pill a day, right? So think about what we're doing now. It's just 1 pill once a day. And so what we're going to look at is these are the things that really sort of drive which of those 1 pill regimens are we going to use. And so what you can see here is RPV, right, seems to be a problem, right? Do you see that in all 3 of those top categories? RPV is rilpivirine, and it's a problem only because you have to take it with large meals, and it's not great for people who are really sick when they're starting treatment. Otherwise, it's great medication. So just don't use a rilpivirine-based regimen, and you'll be okay right off the bat, right? And then that HLA B5701A is, if that test result comes back positive, then that means should you ever prescribe abacavir to that person, that they would get really sick. Now, I'm going to show you a couple regimens to think about. None of them contain abacavir. None of them contain rilpivirine. So we're going to make this really easy for you guys. So here are the recommended regimen choices from the Department of Health and Human Services regarding antiretroviral treatment for rapid initiation. So that means you get a test result and maybe you don't even have all the labs yet. You can still start treatment. And so here they are: bictegravir, tenofovir alafenamide, and emtricitabine, or dolutegravir plus tenofovir alafenamide plus emtricitabine, right? And then we're going to look at the darunavir containing regimen. So why am I pushing you guys to start HIV treatment? You're like, I am in convenient care. You told me they're not that sick. What is the big deal? Well, 2 things are the big deal. One is patients often want to start. They want to do something. You've just given them horrible news, and now they want to do something about it. And so this is one thing you can do as a provider to feel less helpless, is really what I think of it as. The other thing is, we know when we initiate people immediately with rapid ART, it increases uptake of the medicine, it increases engagement in care, and it accelerates times of viral suppression, so you reduce their risk of giving somebody else HIV. So here are the 2 regimens, and I'm going to get to use brand names, guys. I'm so excited. So Biktarvy is the one to remember. Okay, that is the one with the sort of least amount of drug-drug interactions, and it's a single tablet regimen, little tiny red pill: bictegravir, tenofovir alafenamide, and emtricitabine. So if you are going to start HIV treatment in somebody who's in your office with a brand new HIV test, you can feel really confident that if you start Biktarvy, they're probably going to do well. They're probably going to gain a little bit of weight, but that's okay. We're okay with that, right? And then we are going to think about the other option is Simtuza, which is darunavir, cobicistat, tenofovir alafenamide, and emtricitabine. I think that's another great medication option. However, cobicistat is a booster, And so sometimes if patients are on different medications, like even Flonase, that booster can interact with it. And so the safer option for everybody to remember is bictegravir, tenofovir alafenamide, emtricitabine, little red pill, and I'll call it BIC for short. So really your baseline testing, you're going to write that prescription for the bictegravir containing regimen. You're going to do HIV antibody testing, get that CD4 count, figure out, is this like an AIDS diagnosis or is this just asymptomatic HIV? Going to get a CBC, a chem. I would get a CMP. That's what I usually do. I get a BUN creatinine and urinalysis. Look at those hepatitis serologies, fasting blood glucose, serum lipids, and HLA-B5701. We like to get it right away in case you ever need an abacavir containing regimen. Think about genotype testing, and then really think about STI testing. If you didn't get the STI testing before, maybe we get it now, right? Like maybe we weren't expecting this, and so now maybe we need to look at that HIV risk and that STI risk again. And so routine monitoring, let's say you're having a really hard time getting this person to an HIV provider, or they're really nervous about going to an HIV provider because you're like an awesome provider and they love you and you changed their life and you helped them so much. And now they just like don't want to leave you, right? Because that happens. And so what are the things that you want to monitor until you can get them to a more seasoned provider? A CD4 count, viral load, CBC with diff, CMP, STI screening. You're going to do that every 3 to 6 months, right? And that's how you're going to keep this person safe until you're able to get them to that seasoned longitudinal care provider. And this is probably the most important part, is the warm handoff. If you've done this test, if you've given somebody this piece of information, if you've started them on HIV treatment, you have changed their life. You have drastically improved their outcomes. You have drastically improved the outcomes of every single person they will have sex with throughout their entire course of life. And you are such a good public health hero, and I am so proud of you. But you want to make sure that that person now feels just as supported going to the longitudinal care provider. So what I say is, like, pick out a couple in your area, make a phone call, say, hey, I'm going to start doing a bunch of HIV testing. I want to make sure if I need to, can I send people to you? Yes, absolutely. And I used to like go and meet people. Like, I want to know who I'm sending folks to. Are you a good person? What's your waiting room like? Right. And so I think making those sort of relationships is really, really important. The other thing to think about is Ryan White programs are huge programs that have case managers and outreach workers, and they might come and meet a patient at your office with you. So let's say you have a new diagnosis and you're really nervous about giving it. You call up that Ryan White program and you say, hey, can you send me an outreach worker or a peer, better yet, somebody who's living with HIV, to come and sit with me and help this person pick up their meds and like walk through this really, really hard time for them right now. I've never, ever, 100% of the time, this is not a 9 out of 10, 100% of the time, somebody shows up at your office. And they're like, when do I need to be there? It is a really supportive environment. And I really encourage you to sort of meet those people. And then that warm handoff, call that provider with the patient in the room, introduce them over the phone so that they know you think this is a good person and that they're going to get great care with them. Okay. So for those of you who are like, oh my God, you just gave me so much information and I'm really worried about doing this with a patient, don't fret. We have chances to practice. And so these are the Meet the Patient activities. It's going to happen in June. You're going to get an email. I really encourage you to think about this. There's going to be opportunities to talk about starting PrEP, starting ART. And so really, really great opportunities for you to practice that skill set because it does take practice. And unfortunately, I have a lot of it, right? I don't like it, but I think the more you practice and the more testing you do, you're going to get practice and you're going to find people. And that is what we want. And it's sad, but it's also really great.
Thank you so much, Justin. And let's kick off the Q&A.
I can't start HIV treatment in my clinic. How do I refer the patient? Melinda, what do you do?
So that's a great question because I think that's common in a lot of community care, which is why we want to kind of have this presentation so you can see, just be thinking about it, that this is something that we could be doing in convenient care and we should be doing in convenient care. So, but if your clinic isn't there yet, if your corporation isn't there yet, know your community resources. So you know your community local board of health nurse, Know your, who do you call when you have a positive STI infection anyway. And I'm going to actually take that tidbit that Justin said about the Ryan White organization. That's fantastic. So I would write that down and see who your representative from the Ryan White organization is in your area. That's so even though you're not prescribing, you want them leaving your door with access. And if you could have to call that day and make an appointment for them right then, that's great. I fortunately live very close to Howard Brown in Chicago. So I always know at the back, if I've got nothing else I can do, I can always call Howard Brown and say, where can I go? So know your big resources in the community.
Fabulous. That's exactly what I always say. I think the warm handoff is key. We want patients to feel like we didn't just give them terrible information and then leave them alone. Right? We're going to connect you. You're leaving. If you can't leave me with meds, I'm going to get you to somebody who can give you meds.
Right.
And then how do I start a conversation regarding HIV testing when someone comes in for a flu shot? Melinda, what do you do? I'm here for a flu shot.
Oh, that's a great question. You just have to shift your outlook on what you're doing. What is a flu shot is health promotion. A flu shot is disease prevention, and that's all HIV testing is too. So as you're just running through your services of, oh, hey, thanks for coming in, just so you know, we do these other health prevention services too. And so just put it in it's just in your toolbox of ways that you help promote health in your community. So you're drawing up a flu shot and you're saying, oh, hey, thanks for coming in. What brings you in? Thanks for talking to me about it. By the way, we do this, this, and this. Do any of those services interest you? Or can we have you come back to do any of those services for you?
I used to always say any infectious disease can be sexually transmitted, right? Yes. Did you know that? Did you know if you have sex with someone who has the flu, you're probably going to get it. And so then I would sort of use that as my leeway into talking about STI testing and HIV prevention. I think really trying to just have that in your wheelhouse when you need to can be really helpful. And I'm just realizing that we are at 2:05, so we are right at time. Nate, Faith, I'm not sure if one of you wants to say anything.
Yes, thank you so much, Justin and Melinda, for that just completely invaluable information. If you would like to claim credit for this program, please do check your email for a message from the Convenient Care Association. We'll also send a copy of the presentation through email as well, so you can review this on your own time. Again, thank you to everyone. Justin, Melinda, thank you.
Thank you so much.